Good evening, everyone. Thank you for joining us tonight. Welcome to another great WiSH webinar that we have coming up for you. This evening, we are going to be talking to Dr. Jaco Strydom, Dr. Corlia Brandt, who heads up the Women in Pelvic Interest Group from WiSH, is going to be introducing Dr. Jaco Strydom, where he's going to be discussing sport, infertility, and reproductive health. Once again, thank you so much to Asino Lita for sponsoring this webinar. Without them, it wouldn't be possible. And please note that any questions you have, if you can just pop them into the Q&A box, we will be addressing them then at the end of the session. Thank you so much, and over to you, Corlia.
Thank you, Megan. So it's my pleasure to introduce tonight Dr. Jaco Strydom. He studied at the University of the Free State, where he then also specialized in obstetrics and gynecology. He then started working in private practice, and also it was followed by some academic career at the University of the Free State, where he was lecturing and also the head of the unit for human reproduction. An integral part of his interest and expertise includes minimal invasive gynecological surgery, and he has also spent some time at some world-renowned endoscopic training facilities. Since then, he has also hosted several workshops and have performed a couple of thousand endoscopic procedures. So definitely a lot of experience in this field, and we are really looking forward to listening to you, Dr. Strydom. Thank you very much for joining us.
Thank you, Corlia, for the very kind introduction. And thank you, Megan, as well. And good evening, everybody. And it's a huge privilege for me to be able to join you tonight on your webinar as part of your WiSH series. And I see people are joining in all over the world, even from Russia. So sure, I feel very privileged to be able to be part of this evening. I'm in Bloemfontein. I don't know what it's like in Russia, but in Bloemfontein, it's a beautiful, quiet, one of those summer Free State evenings with the beautiful sunsets. So it's a beautiful evening here, but thank you so much for the opportunity. And I'm looking forward to our time together, even if it's via a screen. Hopefully soon we will be able to have meetings again in person. So I'm just going to try and share my screen quickly.
We can see it perfectly.
Is it fine, Megan?
Yes, yeah, looks good.
Okay, so the topic of this evening is sport and infertility. And you will hear me through the evening using the terms sport, exercise, and physical activity interchangeably, because it's usually the activity that have an effect on reproductive health, but where there are specific sports involved, I will highlight these. And then also in terms of infertility, infertility is one of the fields of reproductive medicine. Other areas include female hormonal problems or menstrual issues. And I will also, highlight some of these during this evening as part of reproductive medicine. So it's a very wide topic, and because of the wide topic, I decided to stick to the most common condition that have an effect that is helpful during fertility or reproduction. And then I'm also going to spend some time on the most detrimental conditions or detrimental areas where sport and exercise can be detrimental on reproduction. And then we're going to focus on some other related conditions. And lastly, we'll end with some one or two new recent articles. So I'm going to kick off this webinar this evening with polycystic ovarian syndrome. Now, polycystic ovarian syndrome is something that we really see on a daily basis, and it's by far the most common reason for anovulatory infertility. The etiology is multifactorial and may include a genetic component, but also possibly some environmental factors. And we even think that some of the early intrauterine environment can contribute to PCOS. So there's been a lot of pulling hairs on creating a proper criteria, but since 2003, we've used the best one that we have at the moment, which is the Rotterdam criteria. And according to this, a patient should exhibit signs of excess male hormone, either clinically or via the blood work. Then some menstrual irregularities, usually skipping menstruations or total absence of menstruation. And then lastly, they should have some signs of specific ultrasound signs of polycystic ovaries, meaning large volume ovaries with several small little antral follicles. Now, this is usually, can I just ask, can you see my laser? Can you guys see my laser?
Yes, we can see a laser.
Okay, so this is what a typical polycystic ovary would look like. A large volume with multiple small little follicles on the ovary. Now, I must say, polycystic ovarian syndrome is actually a misnomer because there's absolutely no cysts involved, or there's no cysts on these ovaries. What actually would have been a much better term is something like follicular arrest syndrome, because we often see that the follicles start to grow and then they kind of arrest at the early follicular phase, which is usually about day 6, 7 of the cycle. I think it is very important to just recap the physiology again, because I'm going to spend some time and often refer back at the physiology this evening. So just to recap, the hypothalamus is the area that produces gonadotrophin releasing hormone that is being produced in pulses. If the pulses is a high frequency, then it will lead to LH secretion. And if the pulse is a slower frequency, then it will lead to FSH secretion. And FSH's main function is to stimulate follicle growth, whereas LH's main function is more maturity and actual ovulation. As the follicles grow, the estrogen level rises because it's produced by the granulosa cells of the follicles. And you will see that it peaks shortly before ovulation. And it's of course responsible for the building up of the endometrium in the uterus, the physical line that prepares for pregnancy. So the effects of PCOS is mostly menstrual abnormalities, like I've mentioned, anovulation, infertility, excessive hair growth in a male pattern, then also acne, and even hair loss. But the one that I want to talk about tonight is specifically obesity, the obese PCOS patient. And you can see that about 50% of PCOS patients are actually struggling with obesity. Obesity clearly modifies the PCOS phenotype, especially metabolically, and it also blunts responses to certain treatments, as you will see later on. A further contributing factor or problem is that amongst the 195 countries in the world, South Africa is currently ranked number 90 in terms of obesity. Obesity exacerbates many aspects of PCOS, especially cardiovascular risk, and also risk factors for some female cancers, especially endometrial cancer and breast cancer. Now, it's important to note that on diagnosis of a PCOS patient, especially the obese PCOS patient, almost 8% of them will already have type 2 diabetes, and 1 out of 3 will have impaired glucose tolerance. But it's really the reproductive area that I want to focus on this evening, and I'm going to kick off with a preconception phase. So before pregnancy or in their struggle to fall pregnant, we find that these patients has a decreased ovarian responsiveness to ovulation induction. Ovulation induction means the drugs that we give them to try and help them to ovulate. And also they often need higher dosages of these medication to ovulate. This is just a graph to illustrate one of the problems that we encounter with PCOS. So there's a certain level above which the FSH must rise to induce follicle growth. So we're going to call this the threshold for follicular growth. And then there's a certain level where we will find hyperstimulation of the follicles, meaning she would grow 10 or 11 eggs. And that's typically the threshold that we want to achieve during IVF. But as part of our normal ovulation induction in patients where we want them to achieve a spontaneous conception, the problem with PCOS patients is that the threshold for follicular growth goes up and the threshold for hyperstimulation goes down. So the therapeutic range becomes very narrow. And what you typically would find in practice is you would induce them, try and induce ovulation with a certain dosage of FSH. And then if you do an ultrasound a week later, then nothing happens. Then the appropriate response would be to increase the FSH dosage and do another scan a week later. If nothing still happens, the appropriate response would be to increase the dose further. And then very often with a follow-up scan, you find that she has grown 6 eggs. And then you actually have to cancel the cycle because of the risk for higher order pregnancy. So the cancellation criteria is 4 or more eggs above 14 millimeters. So, and that's the problem with them. The therapeutic range becomes very narrow. And then even in terms of assisted reproduction, in terms of IVF, we find that lower number of oocytes can be retrieved. And also these oocytes are of a lower quality. Even the embryos generated from these oocytes have a lower implantation potential with lower clinical pregnancy rates. And then also there are several safety considerations challenges in terms of rendering a proper service, like maintaining a good airway during oocyte aspiration, doing a proper ultrasound during transvaginal retrieval in terms of oocyte retrieval, etc., etc. In terms of pregnancy, we know that there are an increased risk for miscarriages in these patients. And what is very interesting is it's not an increased risk of chromosomally abnormal pregnancies. It's actually loss of normal pregnancies. So these patients doesn't have an increase in chromosomal abnormalities. I mean abnormal conceptuses, but the loss is actually for euploid embryos or pregnancies. Then there's an increased risk for congenital abnormalities, including heart defects, including spina bifida and omphalocele. They have an increased risk for gestational complications like hypertension, gestational diabetes, preterm labor, and even infant mortality. And then again, the decreased ability to deliver optimal antenatal and obstetric care. If there are any obstetricians among you, they will tell you that these patients actually expect you to do a proper downscreen. They expect you to do a proper anatomy scan. And it's just impossible to have the same kind of imaging that we have with other patients. Not even to mention the delivery issues and the cesarean section issues. And then we also know now that some conditions, late onset conditions, childhood conditions, and adult onset conditions are actually because of intrauterine programming. And this can also occur in this group of patients and give them a higher risk for metabolic syndrome, childhood obesity, childhood asthma, and several others, ADHD and other psychological conditions. So really the mainstay of treatment for these patients is diet, loss of weight, and exercise. There's many people who will treat these patients with several different types of medication. I'm not saying that that is the wrong approach, but I think it's very important to emphasize that it can never be a crutch to avoid the lifestyle change. The lifestyle changes for patients with PCOS is of the utmost importance, and medication is just an add-on to help these patients. So in terms of diet, the compliance and calorie intake are far more important than the specific dietary composition. And I think it's very important to try and keep these patients motivated and emphasize how much can be gained with only a little weight loss. 5 to 10% already produces beneficial effects on the risks of cardiovascular disease and diabetes, and also with reproductive function. But I think the big issue is 90 to 95% of these patients will not maintain weight loss. And I think to summarize it is, without exercise, a diet in these patients is doomed to fail. And there's a beautiful model in a textbook of Professor Leon Sperov. He's being regarded as the father of gynecological endocrinology. And he has a beautiful explanation for this problem. And at any certain stage, there's a delicate balance in terms of your energy intake, which is obviously your food intake, energy stores, which is represented by the fat percentage in the body, and then also energy expenditure. And any disturbance of this balance will lead to compensatory changes, where the body actually attempts to correct either the deficit or the excess. So I'm sure you know that the main components of energy expenditure is the basal metabolic rate, heat production, and physical exercise. In terms of the fat percentage or fat mass, there's a hormone that we call leptin that's produced by the fat cells that will induce, in case of high levels, will induce satiety and decrease appetite. And leptin is actually the signal in the blood that tells the brain about the available energy. Then on the flip side of the coin, you would find ghrelin, which is secreted by the stomach and the small bowel. And increases in ghrelin will have opposing effects to leptin. So this will induce hunger and increase appetite. And at any specific time, when these three are in balance and we have consistent levels of leptin and ghrelin, the body will be at the kind of a set point, and it will try to maintain this balance. So what actually happens with weight loss, or loss of fat, I should rather say loss of fat, then the leptin levels will decrease and the ghrelin will increase, because a diet is nothing else than a controlled starvation. So the leptin levels will decrease and the ghrelin will increase, and this will cause an increase in appetite. But that's not the only thing that it will increase. It will also lead to a decrease in your metabolic rate. And that is an attempt to conserve energy. So this is not a bad thing for somebody who's losing weight because of an illness. The body is trying to conserve the energy to fight the illness. But it's a big problem for an obese person trying to lose weight. This can be so dramatic that a person can not lose any weight with maintaining a strict diet with less than 1,000 calories per day. So there's only two ways of overcoming this problem. First one is to just stay at it. Soos hulle in Afrikaans sê, byt vas, push through and persevere, and with time, the body will lead, there will be a new set point and they will eventually lose weight. But everybody knows how difficult it is to stay motivated if you follow a strict diet and you don't lose any weight. The second, or maybe the much better way to overcome this problem is by physical activity. Obviously, it will increase your energy expenditure, but what is more is it will increase your basal metabolic rate for the next 48 hours. And then with sustained weight loss, these hormonal mechanisms and the energy adjustments will eventually lead to new set points and a new balance for a specific body. In terms of exercise, our patients is really usually very inactive. And I think it's very important to have a realistic goal setting. I must say, one of the most funny things I've ever heard, I don't think it was funny at the time, was one of the patients. When I asked her about her activity, she told me that she was very active. So I asked her to tell me more about this exercise that she's doing, and she told me that, do I know how far she have to walk to go and take a smoke break? It's about 100 meters to go for a smoke break, and she smokes about 10 times during the day. So that was not really what I had in mind. But anyway, so choose an activity that is convenient, that is accessible, and that is enjoyable. And very important is to get it in their calendar first. They must establish a habit and then increase the intensity later on. Good. So for the next part of my talk, I'm going to introduce you to one of my patients. Let's call her Cindy. She's a 30-year-old female and she's married for 5 years. She's been struggling to conceive for the past 2 years and previously had some irregular cycles. But for the last year, she hasn't had any menstrual cycles. She's healthy, no chronic diseases, with a body mass index of 21.9. And she had several visits to a GP for this problem. And each time she goes to visit the GP, he starts her on some oral contraceptives, combination pill, on which her menstruation will resume. And then for 2-3 months after stopping it, then it will completely disappear again. So she was sent to me with some hormonal tests. And as you can see, the FSH level was within the normal range. It was 8.3. The LH was 3.4. That's also within the normal range. And the estrogen level was less than 75. So that was very, very low. On ultrasound examination, I found a very thin endometrium. This is the uterus here. Very thin endometrium, which is probably what one would expect with a very, very low estrogen level. And then the ovaries were also having small antral follicles, small follicles, nothing bigger than 7 millimeters. So I decided to repeat the hormones at least 6 weeks later, and I found pretty much the same type of response. FSH of 8.9, LH of 0.9, and an estrogen that was still very low. So you will hear me say that the FSH is within the normal limits, but I think it's very important to highlight it again from the physiology. So remember, if the FSH is produced by the pituitary, the main action is to stimulate follicle growth from the ovary. As the follicles grow, the estrogen level will rise. And as the estrogen levels rise, they exert a negative feedback on both the pituitary and the hypothalamus to suppress the FSH. And this is like a protecting mechanism to prevent higher order pregnancies. So if the estrogen is very low, those estrogen levels that I showed is actually the same as for a patient that's in the menopausal range. So if the estrogen remains very low, what's supposed to happen is the hypothalamus and the pituitary is supposed to increase the dosages of these in order to try and get eggs. I've recently seen a patient with menopause where the FSH level was 121. So you can see that even though this FSH is normal, it's not normal for a patient with a very, very low estrogen level. And this is a classical example of hypothalamic dysfunction, or some people call it functional hypothalamic amenorrhea. But this is a condition that is brought on by regular strenuous exercise, underweight or chronic malnutrition, and severe emotional stress. What's actually happening here is that there is a low energy availability or even an energy deficit. Now, this has been recognized as early as the 1970s by Rose Frisch, who developed a so-called critical weight hypothesis. Now, he stated that regular menstrual function necessitates maintaining weight above a critical level and therefore they assumed that a certain fat percentage above a critical level was needed. For many, many years, it was a mystery on how total body fat could actually talk to the brain. And now we know that this is also via the leptin pathway. These days, we've changed our thoughts a little bit about this, and that it's not really the level of body fat that have the direct effect on reproduction, but rather that the body fat is only a marker of the metabolic energy state. In these patients, there's extremely thin patients with anorexia or strenuous exercise. And we know that the low levels of leptin is an attempt in these patients to restore appetite. There was a very, very interesting experiment where they would administer recombinant human leptin to women with anorexia. And it would actually increase their levels of gonadotrophins, and their ovarian activity actually resumed after those injections. The only problem with that is, remember what I said before, leptin suppress appetite. So it will, in these patients, will increase further weight loss. So it's not a solution. So low levels of leptin can suppress the hypothalamus, but also corticotropin releasing hormone and ultimately cortisol can also have profound suppression of your hypothalamic pituitary ovarian axis. And this we often find in extreme exercise and severe emotional stress, like with anorexia. So the clinical manifestation depends mainly on the degree of hypothalamic suppression. If you have mild suppression of GnRH, we will only find a luteal phase defect. This means that after ovulation, the progesterone secretion in the second part of the cycle will not be sufficient to maintain it for the full 14 days. And you will probably have some bleeding or spotting before the time and an early onset of menstruation, short cycle. Then if the degree is slightly stronger, if the degree of suppression is slightly stronger, then you will find chronic anovulation. And clinically, you will most probably find patients who skip months in terms of menstruation. And then in case of profound suppression of the axis, you will find total absence of menstruation. Other clinical manifestations may include delayed puberty, infertility, even miscarriages, low bone mineral density with repeated stress fractures, and ultimately osteoporosis. What is very interesting is you will see that these patients do not complain about the normal menopausal type of symptoms, even though their estrogen levels is the same as for a menopausal patient. And this is reflecting the underlying dysfunction of the hypothalamus. So hypothalamic dysfunction is really just the first step towards the so-called female athlete's triad, of which I'm sure that you know very well, which consists of a triad of menstrual disturbance, low energy availability, and bone mineral density. Now, this is often something that we see in the so-called appearance sports, where athletes become overly preoccupied with body size, shape, and composition. Also in sports, endurance sports, and then also in sports where there are certain weight categories like martial arts or rowing. These patients are usually suffering from the be thin to win mentality, and these pressure can usually be inflicted from parents, coaches, or even themselves, and they are at extreme risk of developing eating disorders. Christy Hendrich was a member of the US national gymnastics team who won a silver medal in the all-round competition at the 1989 US National Championships. One of the judges at an international meeting the same year told her bluntly that she was overweight. He actually said she was too fat and that her scores would improve if she lose some weight. Christy took these criticisms to heart, and her drive to lose a few pounds progressed to disordered eating habits and eventually the development of anorexia. Despite many early treatments and hospitalizations, her weight deteriorated to only 21 kilograms before she died at a very young age of 22. Her death brought this problem of eating disorders, especially in women's gymnastics, into the spotlight, and many other gymnasts stepped forward and went public about their disordered eating habits. The focus on gymnast wellness was addressed with several programs on both a national and an international level, with varying degrees of success. But it's difficult patients to treat because they don't really want to hear you explain the truth to them, because actually the problem is that the energy balance is not appropriate. So they need to change their eating habits and they need to decrease their exercise activities. And they often need the help of psychologists to also help them with behavior therapy. Important to screen for eating disorders in these patients, and then also to do a baseline bone mineral density scan. I think it's also very important to highlight to them that the beneficial effects of weight-bearing exercise on bone are not sufficient to prevent the adverse effects of estrogen deficiency. So they will need hormone replacement therapy, and probably the most natural way to do it is with a transdermal estrogen patch combined with cyclical oral progesterone every fourth or 3 or 4 weeks, once a month. The oral combination pill seems to be very often prescribed to these patients, but it doesn't really work as well as the first mentioned treatment. And it seems that the oral contraceptive pill has an effect on insulin-like growth factor, which is a bone trophic hormone, and therefore doesn't have the same benefits in terms of bone health than estrogen alone. When it comes to fertility, we don't treat these patients if they still have a BMI less than 18.5 because of the risk for fetal loss, small for gestational age, and preterm birth. But when you do want to continue with treatment, then careful gonadotrophin therapy is the most appropriate way to help them to ovulate. And the normal type of middle of the road drugs like clomiphene citrate and aromatase inhibitors does not work for these patients. And it's actually easy to understand because aromatase inhibitors decrease estrogen production, whereas clomiphene citrate blocks the estrogen receptors, making the brain think that the estrogen is lower than it really is. But remember, for these patients, they already have rock bottom levels of estrogen, and the FSH is already not responding to what is already very low. So it doesn't help to make the brain think that it is even lower than it already is. Good. So I'm going to move on to anabolic steroids. And according to the World Anti-Doping Agency, 44 to 70% of elite athletes, professional athletes, declare past use. And this figure is even more impressive considering that more than 75% of users are actually non-competitive athletes. So we know that there's a lot of effects of anabolic steroids on hair growth, lower urinary tract symptoms in terms of prostate enlargement, development of breasts, acne, hepatic effects, several cardiovascular effects, even renal failure and psychotic effects. But the ones that I really want to get to is the reproductive effects. So we know that anabolic steroids can cause varying degrees of spermatogenic failure and even total azoospermia, meaning absolutely no sperm cells found in the ejaculate. with long-term use, we will find reduction of testicular volume and also erectile dysfunction and loss of libido. This is a semen analysis of one of my patients. He's a 45-year-old male. He has 2 kids of his own and is currently in a new relationship. He admitted to be using parenteral steroids for about a year. By the time I saw him, he has stopped it for a couple of weeks. But you can see that his volume, the volume of the ejaculate was very low. That's supposed to be 2 milliliters. His sperm concentration was very low, 0.4 million per milliliter, meaning 400,000, where it's actually supposed to be more than 20 million. And because the volume is so low, his total count is the same, whereas the total count is supposed to be more than 39 million. So even though I know it doesn't sound correct to say if there's a sperm cell, there's a chance for conception, but it doesn't really work like that. There's no way that this individual will be able to impregnate his wife. So when we look at the male hormones, you will see that his FSH level was very low, his LH level was very low, and his testosterone was within the normal limits. Now, this might be because he has already stopped his steroids. Very often we find that the testosterone is very high, but it might also be that because of the specific type of steroid that he used, I can't even remember what he used. The further away the structure from testosterone, the less likely it will be picked up as testosterone in the blood. So we all know that testosterone is extremely important in terms of sperm production or spermatogenesis. So the question is, why then, if you administer either testosterone or steroids, which has a testosterone-like effect, why will it then result in spermatogenic failure? And the reason or the key lies in the intratesticular levels of testosterone. The levels in the testes is 50 to 100 times higher than in the blood. So LH is responsible to stimulate the Leydig cells to produce these levels of testosterone. And any parenterally administered steroid or testosterone, that's per mouth or IM or whatever the routes they injected, can never achieve the same intratesticular levels that is necessary to maintain spermatogenesis. Another important feature to highlight is the FSH. So remember, the FSH has a huge action on the Sertoli cell in order to generate male hormone receptors on the cell and then facilitate spermatogenesis. So number one, the testosterone level is not adequate, and number two, the FSH and the LH was very, very low in this individual. Luckily, most of them recover, but it can take up to 2 years to reach a full recovery. And the time to recovery usually depends on the duration and the dosage that they used, and also the age of the patient. So the easiest way is just to wait for it to return. But the problem is, if you have a female patient that's 38 or 39, then her chances are also much lower to actually conceive. And you might not have the liberty to wait the full 2 years for a complete recovery. In this case, we would treat them hormonally with recombinant human chorionic gonadotrophin. That's HCG. That's a pregnancy hormone. The pregnancy hormone has very potent LH-like activities. So it will fulfill the duties of LH. And then also we will then inject them with menopausal gonadotrophins, which is very high in FSH. But even if you use this approach, you'll still find that it takes quite a long time, at least 4 to 5 months to return to the normal values. And the reason for that is we first have to wait for normal testosterone production in the testes, and then one sperm cycle is 70 days. So if somebody does a semen analysis today, then it actually reflects what happened 70 days ago. And then the transport is another 2 to 3 weeks. So it's about 4 to 5 months, depending on the time that it takes for testosterone levels to rise, that you will have to wait for a change in that semen analysis. Another related topic and question that we often get is the so-called protein supplements that many of the young athletes and especially the gymmers are so fond of. And I must say, we don't have a lot of good data on whether it's detrimental or whether it's helpful. But I think the best article that we have is this one, Infertility and Sterility, which is a recent one, last year, July 2020. And even though that this is a cross-sectional study, it's a birth cohort study which relied on self-reporting of protein supplement use, but at least it seems as if there's no association between the use of protein supplements and semen quality characteristics. Most people in this study used whey protein or creatine, and I must say the soy-based supplements was not really, there was not a lot of patients that use those kind of supplements in this study. So I think there are definitely the need for more studies before we can draw a firm conclusion on this. And then lastly, there was a very interesting study on physical activity and the effect on semen quality. And this was a systematic review, also quite recent, as you can see, 2019. And they looked at different types of sport and activity overall. So they identified 17 articles that they included, and they divided them, the patients, in 3 groups: recreational moderate intensity physical activity, and high intensity physical activity, and then the so-called endurance group, the elite physical activity group. And the results were actually very predictable. Both the recreational type groups, moderate and high intensity physical activity, seem to have a trend towards a positive effect on semen quality. There was definitely no adverse effect. And if you looked at the subgroup of infertile population only, then this trend was definitely showed a more positive association. But the extreme athletes, the endurance athletes, has been repeatedly correlated with a decline in semen quality, and specifically the volume, the concentration, the total motility, and the morphology. And what I can tell you is these are the 4 most important parameters that we look at if we judge a semen analysis. They also looked at sports in specific, and they highlighted cycling, and then all the types of sport where traumatic brain injury happens quite often, like boxing and rugby or American football and ice hockey. And what is also news to me is that it seems that the HPO axis are far more frequently affected by these injuries than we previously thought. And as we have seen tonight, we know that pituitary function is extremely important for fertility, and that the decrease in this may definitely compromise fertility. And then in terms of cycling, there was only 2 studies with adequate numbers that we could really look at. And this was not really a normal population. These studies looked at couples attending a fertility clinic. So I cannot draw this results or apply it to the general population. But in couples attending a fertility clinic, meaning the patients who come to see me, there was definitely association with decreased sperm concentration and a low total motile sperm count in the group who were bicycling for more than 5 hours. So to conclude, and there are other articles as well that I haven't even included tonight, which shows very much the same thing. For instance, exercise before IVF. it seems that there's a trend towards improvement, but only for the patients with the recreational type of activity, and the extreme exercise is often detrimental to reproduction. And I must say, if I have to choose my patient, I would rather choose an active patient, even if she's a little bit overweight, than a patient that's completely off normal weight, but that is very inactive. Thank you so much, and thanks again, Corlia and Megan, and thank you everybody for having me this evening.
Thank you very much, Jaco. There's a couple of interesting questions in the Q&A. So I'm going to read the first one, but you can also have a look. It's a long question. So they're asking, why are those involved in infertility management, especially in elite level athletes, so resistant to applying therapeutic use of exemptions, as some medication used are on the WADA prohibited list? Some are part of national or international testing pools that test in and out of competition, and should there be an adverse analytical finding, and in place, TUE can avoid the added stress of dealing with contravening the anti-doping regulations.
Corlia, your sound is very soft. Is there a place where I can read this question?
Yes, sorry. In the Q&A section at the bottom, you can just click there.
Okay.
Can you see it there?
Yeah, I can see. It's quite a long question. So
Yes.
the question is, why are those involved in infertility management, especially in elite level athletes, so resistant to applying for therapeutic use of exemptions, as some medications? I wonder if the question is now, those in infertility management, is it like us, the physicians treating these patients?
Yeah. Sounds like it.
Why are we so resistant to applying for therapeutic use of exemptions, as some medications used on the WADA prohibited list? Some are part of national, international testing pools that test in and out of competition, and should there be an adverse finding? So I would just like to know what type of drugs, are actually on these lists, because then it will be easier for me to say, why is there a resistance to, I don't know if there's, what can one do? If I understand the question correct, is it so the doctor can say, listen, this patient is on treatment, and this is the reason why she's on treatment? Is that what she means or not? Because I must say, for myself, I've never had a request for anybody to apply for therapeutic use of exemption, as they put it, from any athlete.
I see you replied at the bottom, there are several stimulants and hormonal medications on the list.
Yeah, so I think stimulants is a very broad topic, né? So the things that we usually use as part of infertility treatment are mostly FSH and LH, and sometimes the anti-estrogens. So I'm not sure which of those are actually on the list that might not be used, but I assume that anything that can be or converted to testosterone would probably be on the prohibited list. But I must say, I've never had this request from any of my patients to apply for something like that. So I can't really answer that.
Then there's another question. Can side effects of anabolic steroids be reversed once the use is stopped?
Yeah, so that's a good question, and it depends on the duration of use, and also obviously on the timing that they use it. So I can't really say yes or no, but definitely there will be some reversing of some of the effects that will have the ability to reverse. I mean, if just like the reproductive effects will reverse, but if somebody, for instance, I can take an example, like for instance, hypertension. If they stop treatment, then that's something that will also reverse. But if they have renal failure, then that's not something that will be reversible. Nay. So I think it will depend on the different type of effect, but then also on the duration and the level of usage.
Okay. So I see you posted the website, so we can just share that on the chat. I will do that. I just also have a question, Jaco. So when patients are receiving treatment, do you need to change their activity levels due to the treatment, or do you just continue basically addressing, as you now said, whatever the cause might be, whether it's increasing or decreasing activity? But so when they are receiving treatment, does that change on what you do with their activity levels?
Mm-hmm. Yeah, I think if a patient does not have these conditions that I referred to, we don't decrease their level of activity. Okay. I think going through infertility treatment can be very stressful, né? And so the last thing that I want to do is to ask somebody who's used to running 5 days a week to decrease her level of activity. So no, as long as she has normal cycles, as long as the energy balance is normal, then we don't decrease their physical activity.
Okay.
Even in pregnancy, nay, even in early pregnancy, we don't decrease it.
Yes. Okay. So I don't see any more questions at the moment. So then thank you very much for this very interesting lecture. I think you really, nailed it with the topics and the content that you presented tonight. Very applicable to the whole sports situation. I think it's not things that we know about the topic, but don't really go into detail in it sometimes. And there's a lot of information that I think is very useful for us. So thank you very much for your time and the effort that you've put into this. So I'm just going to hand over to Megan again, then just maybe to close this webinar, and thank you again for your time.
Thanks, Corlia.
Thank you so much, Corlia, and thank you, Jaco. That was a really informative talk, and I like how you covered the different elements of infertility and reproductivity with regards to sport and maybe people who aren't actually that active. Yeah, it really was a great talk, and thank you so much. This is actually our last webinar for the year, so thank you so much for closing it out with such a great topic. And then for next year, we haven't yet scheduled too many webinars, but there is the first WiSH Congress, which is going to be from the 11th to the 13th of March, 2022. So you can look out for it on our Twitter or Facebook accounts, and please save the date.